Welcome back to gastroenterology and the wonderful world of GI bleeding. The first and most important thing about gastrointestinal bleeding is the subject of fluid resuscitation. Now, I know you think it's etiology, but it's not the etiology. It's based on the severity. It's not the etiology. It's based on the severity. So you got a 72-year-old guy with a history of aortic stenosis. And this 72-year-old guy with a history of aortic stenosis comes to the emergency department with red black stool over the last day or two. And this red black stool over the past day or two comes in with red black stool the last day or two. His blood pressure is 94/60 and his pulse is 105. The guy comes to the emergency department and the pulse is above 100. The systolic blood pressure is 94, 105, 110, 112. Doesn't matter. Systolic at 94, systolic at 96. Doesn't matter. 92, 94, 96. And red black stool 5 times, 4 times, 6 times. Doesn't matter. Close enough for government work, as they say. I'm so predictable. What's the next best step in the management of this relationship? What's the next best step in the management of this patient? The wrong answer is to say endoscopy. The wrong answer is to say NG tube. Endoscopy should be done, but it's not first. Nasogastric tube. This is one of the only patients in whom it might be useful, but you can see that we got a lot of room here. And nasogastric tube is not first. Nasogastric tube is not first because the major point of nasogastric tube is to determine, do you do scoping from above first, or do you scope lower first? The nasogastric tube is one of the least useful things. Now, I know that other people told you it's the most useful, and I know that other people said slip them the tube first, but nasogastric tube is always less important than fluid resuscitation. Bolusing this person with either normal saline or Ringer's lactate is far more important than nasogastric tube. If somebody else says nasogastric tube, you should question them. You mean after the fluid resuscitation, right? Oh no, he told us nasogastric. Excuse me, what did I tell you? You mean after the fluid resuscitation, right? And then they'll say, you're right, after the fluid resuscitation. It's good to put in the nasogastric tube. It's good to put the tube in. But if you skip certain steps and you go straight to the tube and do it first, then it won't be special. So you should always do a few things first. Buy them a drink. Test out the waters. CBC, bolus of fluids, before we go straight for the tube. Oh, hose monsters out there. So therefore, fluids, blood, bolus of saline and Ringer's lactate. CBC, you're looking for 2 things, the hematocrit and the platelet count. And you're looking for the hematocrit and the platelet counts because if the hematocrit is low, if you're an older guy like this with a history of aortic stenosis, people above 60, people with heart disease, they should get transfused when the hematocrit is less than 30. You should get a unit of packed red blood cells. Packed red blood cells. If you're younger, healthy, 27-year-old video guy, let him get a hematocrit of 25 or 20. Why put another pint of blood into him? He'll make his own blood cells. Motorcycle accident, gets cut, gets beaten up, girlfriend stabs him in the neck. Then you let his hematocrit go down to 20 or 25 because he'll make his own blood cells over a couple of days. Old guys with heart disease, keep that hematocrit high. Younger people with no heart disease, let the hematocrit go under 25 for sure. And the reason is that the oxygen delivery to tissues, is a function of three things. One, how much blood, hemoglobin, hematocrit. Now, whichever one you like to work in, it doesn't matter, because for every 3 of hematocrit, there's 1 of hemoglobin. So whatever you want to do, as long as you remember there's a relationship of 1 to 3, it doesn't matter. Whichever one you're used to working in. The hemoglobin or the hematocrit times the cardiac output. In other words, you got this amount of blood, but how much of it are you moving per minute with that cardiac output? Maybe you got a hematocrit of 70, but your heart's beating like this. Kaboom. Kaboom. Why, then you're not moving much oxygen forward, are you? Well, if you have a high hematocrit, but you're not moving any oxygen forward because the cardiac output is poor, well, then you're not delivering any oxygen. Listen, I might have trucks that are packed with food, but if I'm only delivering 1 truck a week, I am not delivering a lot of food. It's the same concept, times the percentage saturation. It's no different than trucking business. How many trucks you got? How often are you sending those trucks out? And how filled up are the trucks? It's no different than looking at the trucking business or the shipping business. How many ships? How fast do you send them out? And how filled are they? When you have anemia and you have a markedly decreased hematocrit, you have decreased your oxygen delivery. And that's why the person who's an older guy, who's got a history of heart disease, is much more vulnerable to decreases in oxygen delivery. The guy who's the older guy, heart disease, is much more vulnerable because he can't handle the decrease in oxygen delivery. Now, the platelet count less than... we should transfuse platelets. A platelet count less than... the platelet count less than... I bet some of you are thinking 20,000. I was once young and foolish like you, and I thought it was 20,000 also. But 20,000 is the number for when you become at risk of spontaneous bleeding. That's when you become at risk of spontaneous bleeding. So spontaneous bleeding develops at under 20. When you're actually bleeding, you don't transfuse unless the platelet count goes under 50,000. When the platelet count goes under 50,000, that's when you transfuse, when you're one of two things. Gonna undergo surgery, I'm gonna cut you, or you're already bleeding. I don't have to cut you, you're already bleeding. So when the platelet count is low, then you transfuse when you're gonna get cut or you're already bleeding. Old guy, give him a lot of hemoglobin. He needs a lot of oxygen carrying capacity because his heart's going to die if you don't. Now, platelets, if the platelet count is low, low if you're bleeding and low if you're surgery, is 50,000. Now, what should everybody get? A prothrombin time, the PT. If the platelet count is down, you're going to get platelets. If the prothrombin time is elevated, you're going to give fresh frozen plasma. If the prothrombin time is up, you're going to give fresh frozen plasma. And why are you going to give fresh frozen plasma? Because it works instantaneously. The fresh frozen plasma works right away. Vitamin K takes time. That's why we're not going to give vitamin K right away, because vitamin K takes time. So, therefore, fresh frozen plasma works instantly. Vitamin K takes time. Now, fluids, blood, platelets, plasma, fluids, blood, platelets, plasma, fluids, blood, platelets, plasma is far more important than knowing etiology. In other words, if this person needs upper endoscopy, and this person has an upper gastrointestinal bleeding, the most common cause for severe upper GI bleeding is ulcers. Gastritis, ulcers is number one. The most common cause of significant upper GI bleeding is ulcers, but it can also be esophagitis, duodenitis, gastritis, Mallory Weiss. It can be any one of these. Meckel's diverticulum, esophagitis, gastritis, duodenitis. Now, although I would like to know the etiology of the GI bleeding, and you would like to know the etiology of the GI bleeding, we'd all like to know the etiology of the GI bleeding. However, it doesn't change acute management because fluids, blood, platelets, plasma, fluids, blood, and platelets, plasma doesn't change in any of these. If you have gastritis with bleeding you down to a hematocrit of 20 and you have platelet count that's low, you're going to give fluids, blood, and platelets, and plasma. And whether it's lower GI bleeding, whether or not it's number one cause, diverticuli, RIV malformations, also known as angiodysplasia, dysplastic blood vessels, evil blood vessels, or whether it is inflammatory bowel disease, or whether it is cancer, with these two things being number one, it doesn't change the acute management. Fluid, blood, platelet, plasma is more important than etiology. Why? Because you're not going to die today of whether or not it's gastritis or whether it's Helicobacter pylori. You'll die today if your heart does not have enough oxygen carrying capacity. Oxygen carrying capacity is everything. You want to give the blood. You want to give the fluids. When someone shows you a scope, you say, I want to give the fluids. I want to give the fluids. You want to give fluids. You want to give blood. You want to give platelets. You want to give plasma. You can always put the tube in later. The point of the nasogastric tube is to see whether that black stool might be from an upper GI source. This case is specifically geared to make sure you understand that fluids, blood, platelet, plasma is more important than specific etiology. Now, why are orthostatic blood pressure measurements not useful in this guy? Orthostasis is a nice thing. In other words, orthostasis. I have a greater than 10 change in pulse between lying down and standing up. My pulse goes up. Well, everybody's pulse goes up. When they go from lying down to standing up, everybody's pulse goes up. Mine does too. Yours does too. But I have an autonomic nervous system. And my autonomic nervous system will correct that pulse in 1 minute. So although when I go from lying down, lying down to standing up, my pulse will go up, but it won't go up 30 points, and it will come down in a minute.